the hypothalamic region. Now, we were talking about the mammillothalamic tract, which goes from the mammillary body towards the thalamus, basically mammillothalamic tract, reaching the anterior nucleus of the thalamus. Here, the examiner has given us one histological picture and is asking for the wrongly matched pair. And as we notice that there is marker ABCD with the options given here as marker A cilia, marker B goblet cell, C is the nuclei of the epithelial cells, and D is lamina propria. As we can make out, it is a microscopic picture of respiratory epithelium, which is pseudo-stratified ciliated columnar epithelium, and is evident that marker A is definitely the cilia, fine hair-like processes on the apical surface of the epithelium. And then we can also notice that the marker B is representing a cell which is having one empty looks, and it is basically the mucus which gives it that look. Choice number B is the goblet cell, and that is also a correct marking. As I will show you one of the mucus containing cell here, it appears like a goblet. And in the goblet, you have the mucus, which is being secreted towards the apical surface of the epithelium. So this is the goblet cell. No problem with choice number B as well. Now, choice number C is telling us about the nuclei of epithelial cell. As we mentioned, it is pseudo-stratified ciliated columnar epithelium with few basal cells, and some of the cells are tall, columnar, but still attaching to the basement membrane. So here is one of the basal cell in the epithelium, which has a short length, whereas there is one tall cell as well, as you see here, which will be bearing the cilia. The cilia help us to move the secretions which are there in the respiratory lumen. And here we have got the nucleus of the taller cell, and this is the nucleus of the shorter cell. Since being placed at different levels, appearing like stratified, but it is not exactly stratified since each of the cells are attaching to the basement membrane, hence called pseudo-stratified. So pseudo-stratified ciliated columnar epithelium with goblet cells. What about the marker D? And now you can notice the marker D is basically eosinophilic homogeneous structure, which is called as the basement membrane, a term which is used in light microscopy, generally not very evident but is seen here, and it is understood that this is going to be our answer. Since the marker D, they are mentioning it as lamina propria. It should be the wrong pair and our answer, because marker D is basement membrane. Then what is lamina propria? Lamina propria is subepithelial connective tissue, and it will be below this epithelium. This area below the basement membrane will be the lamina propria, and it is basically going to be loose areolar connective tissue. So that loose areolar connective tissue is the lamina propria and can be seen in one more diagram, but we'll keep our answer as choice number D here. And as you notice in this microscopic picture, again we have the respiratory epithelium. Maybe we have taken it from the trachea. Pseudo-stratified ciliated columnar epithelium with goblet cells. As you can make out, these are the hair-like processes, the cilia, which will be moving the contents of the respiratory lumen outside. Say for example, we have inhaled some dust particles and must be coughed out. So cilia help us to move them outside the respiratory tube. You will notice at the base of the cilia, there is deeply eosinophilic line being observed. That is basically the basal bodies, which help us to move the cilia. And it appears like one deeply eosinophilic line under the cilia. Cilia are on the apical surface of the epithelium, which we can see here, the pseudo-stratified ciliated columnar epithelium. Multiple levels of the nuclei. Some of them are basal cells, shorter in height, and then there are taller cells as well. The nuclei at a higher level, giving us the wrong impression of being stratified, but since all the cells are attaching to the basement membrane, it is not stratified. We call it as pseudo-stratified ciliated columnar epithelium with the goblet cells. So these are the goblet cells. They are giving an empty look in light microscopy because they contain the mucus, which has minimal staining here. So G is the goblet cell, and as you will notice, the N are the nuclei, as we have shown here for the epithelium, and they are sitting on this basement membrane. So this BM, as you notice, is the basement membrane. It will have two components, the basal lamina and reticular lamina. Basal lamina contributed by the epithelium and reticular lamina contributed by the connective tissue, which is subepithelial. This subepithelial connective tissue is loose areolar connective tissue, and we call it as lamina propria. Remember, it will be cellular. There are cells seen here in the lamina propria, which is not evident in the basement membrane. Now let us magnify the region of basement membrane to show its two components. And as is evident, we already mentioned, the epithelium is sitting on the basement membrane, and this basement membrane is having two components, the basal lamina and reticular lamina. The basal lamina part of the basement membrane will have the collagen fibers contributed from the epithelial side, whereas the reticular lamina part of the basement membrane will have the reticular fibers and is being contributed by the subepithelial connective tissue, which we mentioned it is loose areolar connective tissue, the lamina propria. And it has cellular components as compared with the basement membrane because it will have more of fibrous structure. So in our question, we notice that the basement membrane was marked as lamina propria. Let us go back to the question now. And as we already mentioned, the wrongly matched pair is actually choice number D. Since it is not lamina propria, it should be the basement membrane. Lamina propria is below the basement membrane. And this basement membrane was having two components. One contributed by the epithelium, which is basal lamina, and one is the reticular lamina contributed from the connective tissue beneath it. The examiner has given us one electron microscopic picture and is asking about respiratory distress syndrome, which might be happening due to involvement of certain type of cells. So which of the following marked cell would be involved? As we understand, respiratory distress syndrome may occur due to deficiency of the surfactant, surface active agent, which lines the inner side of the alveoli so as to prevent their collapse. If we have deficiency of surfactant, then the surface tension generated within the alveoli cannot be countered and alveoli they collapse, leading to respiratory distress syndrome. Surfactant, more specifically surfactant lipoproteins, are being secreted by the type 2 pneumocytes. And that is what we have to find out here. It says electron microscopic picture of the alveolar region, and what we need to find out is about the details of ABCD marker. So what is marker A? Actually, it is a cell showing this nucleus here, and as we can make out, there is another similar nucleus which is here and another one which is here. In fact, they are the nuclei of the endothelial cells lining the capillaries. Endothelium is simple squamous epithelium, and normally the nucleus should be having a flat appearance, but not necessarily. It can be globular as well. So what is this marker A? It is the capillary endothelium. Then what is marker B? Marker B is basically a cell showing the nucleus here, and this cell is quite large globular cell with a central spherical nucleus. It's a cuboidal cell. It is the type 2 pneumocyte, which is supposed to secrete surfactant lipoproteins, which themselves can be seen as the content of type 2 pneumocyte. So basically, we have to train our eyes to identify the type 2 pneumocytes, cuboidal cells, central spherical nucleus with surfactant lipoproteins. And that should be our answer, marker B. Now you have got your answer, fine, but what about the marker C and D? Marker C, as you can see, alveolar macrophage to phagocytize any foreign substance, maybe some microorganism, etc. It'll have pseudopodia-like structures, can move into the alveoli as well. And then the marker D, as you will notice, it is very thin cytoplasm and is a simple squamous epithelium. The type 1 pneumocyte, which is covering most of the surface area in the alveolus. And because of its thin epithelium, it will be helping us in respiratory gaseous exchange, which we can see in the next coming diagram. Now, when it comes to the alveoli, you will notice the alveoli, most of the surface area is being covered by a cell, which is simple squamous epithelium. And intermittently, you may have the type 2 pneumocyte as well. Let us first focus upon type 1 pneumocyte here, having very thin appearance. And we can show its nucleus as well. Since it is a simple squamous epithelium, the nucleus will be flat or maybe globular. So here, this is the type 1 pneumocyte, which is working for respiratory gas exchange. Interspersed between them could be type 2 pneumocytes, which are cuboidal cells, so they will have central spherical nucleus. And will have some surfactant lipoproteins as well, so as to secrete the surfactant which will line the inner surface of the alveolus to reduce the surface tension, preventing the collapse of the alveoli. So this is type 2 pneumocyte. Now let us show the same type 1 and type 2 pneumocyte in this diagram. As you notice, this is a type 2 pneumocyte here, which is cuboidal cell, and it will be having central spherical nucleus shown here. And it will also have the surfactant lipoproteins. As we mentioned, it is working for production of surfactant. So these are the contents which we are talking about. But it will be covering very less of the surface area of the alveolar lumen, because the alveolar lumen is mostly being covered by type 1 pneumocyte, which, as you can see, will have very thin cytoplasm. And if you are talking about the nucleus, it is flat or globular, as we have noticed here, the type 1 pneumocyte, and we will find that it is covering most of the surface area of the alveolus, except for some part which is being lined by the type 2 alveolar cell. Otherwise, you can continue here. Rest of the surface epithelium is this particular type 1 pneumocyte here. Now, this type 1 pneumocyte, since it is very thin, it will help us in respiratory gas exchange. The alveolar lumen will have good amount of oxygen when we breathe in, and that oxygen will be transferred towards the RBCs, the blood in the capillary lumen. And from there, the CO2 must be transferred towards the alveolar lumen so that we can send it out through expiration. Now, the respiratory membrane will have cytoplasm of type 1 alveolar cell. Then there will be some basal lamina on which the epithelium is sitting. And then we'll have the simple squamous epithelium, the endothelium lining the capillary itself. So here is the endothelial cell, which itself is simple squamous epithelium, as you can notice, contributing to the respiratory membrane. And the nucleus of capillary endothelium is obviously a flat nucleus, or sometime it may be globular. So here is the capillary endothelial cell. And within the capillary, we have these RBCs, and this respiratory membrane is now helping us in exchange of the gases. O2 coming out from the alveolus towards the capillary lumen, and from the capillary lumen, the CO2 is moving inside the alveolus. We can show the same thing here as well. So this is the capillary endothelium lined by the simple squamous epithelium. As we have shown, the nucleus here will be simple squamous epithelium, flat nucleus, or sometime maybe globular. So the same story here. And now we have the alveolar lumen sending O2 into the capillary side, and capillary sending the CO2 towards the alveolar lumen. The respiratory gas exchange is going on through this thin respiratory membrane. The two squamous cells align with each other, and in between there will be basal lamina. As we have observed, that is the basal lamina on which the type 1 alveolar cell was sitting, and it contributes towards the respiratory membrane here. And what is the function of the surfactant secreting type 2 pneumocyte? Of course, it will give the surface active agent which will line the inner surface of the alveoli, like one alveolus is here, the other alveolus is on this side. And if there is pathology involving the type 2 pneumocyte, then the surfactant will be missing, leading to respiratory distress syndrome. In COVID-19 as well, it has been mentioned type 2 pneumocyte can be involved, deficiency of surfactant, and the respiratory distress syndrome might occur there as well. Plus, you can notice one cell here, the alveolar macrophage. You can see it is giving a pseudopodia and is trying to pick up some antigen, which could be some microbial agent. Phagocytosis is going on. It is a very large cell with multiple pseudopodia, and the inclusions could be the breakdown products of various antigens. It has phagocytosed. And then we can go back to our question, where we already have found our answer. Since it is asking for the cell which is involved in respiratory distress syndrome, maybe in a neonate or maybe in SARS-CoV-19, it is the type 2 pneumocyte identified by a central spherical nucleus with surfactant lipoprotein as inclusions, lining a very small surface area component of an alveolus. Hence, we have taken our answer as choice number B here. We could also see the thin epithelium belongs to either the type 1 pneumocyte, or it could be the capillary endothelium, which is not always having a flat nucleus, could be globular as well. So choice A is the nucleus of the capillary endothelium, whereas marker C is the alveolar macrophage, identified by the fact that it will have multiple pseudopodia and will have inclusions, which could be the breakdown products of some antigens it has eaten up there in the defense mechanism as such. Then we get a question which is a sagittal section of the brain, asking us about some fibers which are coming from the arrow-marked structure will be terminating which nucleus of the thalamus. Now, as we talk about the various nuclei of thalamus, that could be the anterior nucleus, posterior, ventrolateral, reticular nuclei. What we need to find out is where is this arrow mark pointing? And in a sagittal section of brain, this is the telencephalon, where you have the cerebrum, the diencephalon, which will be the thalamus hypothalamus. In the hypothalamus region, we have got this structure, the mammillary bodies, at the floor of the third ventricle. Below that is the brainstem, where you'll have the mesencephalon midbrain, the metencephalon pons and cerebellum, and melencephalon the medulla oblongata. There is the third ventricle here. At the floor of third ventricle, you have mammillary body. Then you have the fourth ventricle here, sandwiched between the cerebellum at the roof and pons anteriorly as the floor. But anyhow, if you say this arrow mark structure is the mammillary body, what exactly are you talking about? The mammillothalamic tract is one major tract coming from the mammillary bodies going towards the thalamus. What you notice here is the thalamus region showing the interthalamic adhesion. One-sided thalamus is connected to the other sided thalamus with interthalamic adhesion. That connection is evident here, and it belongs to thalamus. So there is a mammillothalamic tract which belongs to Pepe's circuit. We have to talk about the Pepe circuit here. But which nucleus of thalamus in the Pepe circuit? It is the anterior nucleus of thalamus. Hence, our answer should be choice number A. And let us look at some more details now. We need to talk about the hypothalamus, where you have seen the mammillary body, the thalamus, where you have seen the interthalamic adhesion, and we also want to talk about the fornix at the roof of the third ventricle, as evident here. And we should also know about the cingulate gyrus lying above the corpus callosum here, because cingulate gyrus is also a component of the Pepe circuit. It is all about the limbic system related with the memory and learning. It's a neural loop. Let us look into some more details of the Pepe circuit. So the diagram which we were having was a sagittal section of the brain, and we are looking from the side view. Anterior posteriorly we have taken the section, and the arrow mark was actually at the mammillary body, the hypothalamic region. Now, we were talking about the mammillothalamic tract, which goes from the mammillary body towards the thalamus, basically mammillothalamic tract, reaching the anterior nucleus of the thalamus. Thalamus was identified by the fact that it will be having one interthalamic adhesion, which is connecting one-sided thalamus with the other-sided thalamus. So this is the thalamus region. Below that is the hypothalamus region, and they're communicating by mammillothalamic tract. Anterior nucleus of thalamus was our answer. Then what about this cingulate gyrus, which is above corpus callosum here? So let us look at the neural loop itself, which is known as the Pepe circuit in the limbic system for learning and memory. It all starts with the hippocampus, which is the seat of recent memory. So talking about the Pepe circuit, And starting from the hippocampus, you are sending some fibers towards the mammillary body first via the fornix, as evident here. The major output tract from the hippocampus, the fornix, taking information to the mammillary body, and the mammillary body itself sending mammillothalamic tract towards the anterior nucleus of the thalamus. And from there, the neural loop will send information towards the cingulate gyrus, which then sends it back to the hippocampus. So it is a neural loop which keeps working, converting the short-term memory into long-term memory, or maybe helping us in learning. It also relates with our emotions. So let us mark the hippocampus here. This is the region of hippocampus. The short-term memory is being received here in the region of the temporal lobe, and then it is using the fornix to send the information towards the mammillary body, which you can show now. Hippocampus using the fornix to send the information towards the mammillary body. Now that is the fornix, which goes in a circular fashion, forming the roof of the third ventricle and reaching the mammillary body at the floor of the third ventricle. And this mammillary body has to send mammillothalamic tract, which you can once again see here, reaching the anterior nucleus of thalamus. And from there, you need to send the information towards the cingulate gyrus. As you reach the cingulate gyrus, it will then send the information back towards the hippocampus, as we have noticed earlier as well, shown here, from the cingulate gyrus towards the hippocampus. So here it is a simplified diagram, but in fact, it is one turn and another turn here. So what do we start with? The hippocampus, and then fornix reaching the mammillary body, and then mammillothalamic tract, and then reaching the cingulate gyrus, which then sends the information back towards the hippocampus. So anterior nucleus of thalamus sending it to cingulate gyrus, reaching back to hippocampus. The Pepe circuit. The arrow mark was actually at the mammillary body. And then we go back to the question, where we already have marked our answer. If you are talking about the mammillary body, the fibers will be reaching anterior nucleus of the thalamus. Choice number A is our answer. The mammillothalamic tract reaching the anterior nucleus of the thalamus. A histological picture of the cerebellar cortex with an arrow mark. They're asking the marked cell is going to inhibit which of the following structure. First of all, we should be able to identify the various cells in the cerebellar cortex, and then we can talk about it'll be sending inhibitory fibers to which nuclei. It's a repeat question, and we are actually looking at the middle layer of the cerebellar cortex. There are total 5 cells in here. The outer molecular layer will have the stellate and the basket cells, and the middle layer where the arrow is pointing is the largest of all the cells with multiple dendritic processes towards the outer molecular layer is the Purkinje cell layer in the middle. And then we have the inner GG cell, the granule and Golgi cell. This is going to be a dense layer. A lot of nuclei can be seen. So inner granule and Golgi cell, outer stellate and basket cell. Middle there is this Purkinje cell with the largest nucleus, the largest of all the cells. There are total 5 of them. A question will come, out of these 5 cells in the cerebellar cortex, which is the only cell having outgoing fibers or efferent fibers? The answer is Purkinje cell. Purkinje cell is using GABA, gamma aminobutyric acid, so it is inhibitory. But then it is inhibitory to which target structure? And it could be the dentate nucleus, the deep cerebellar nucleus. And that gives us the idea. The answer to this question should be choice number B, the deep cerebellar nucleus, like the dentate nucleus. Cerebellar circuitry is another topic which we have to work upon, but presently the answer to this particular question, the Purkinje cell, inhibitory to the dentate nucleus or deep cerebellar nucleus, choice B should be our answer. The examiner has again given us one sagittal section of the brain with an arrow mark at the floor of the fourth ventricle which is filled with CSF, having a roof of the cerebellum posteriorly, and the floor is the brainstem. Mostly it is the pons region, and the arrow mark is towards the lower pons here. And then they're asking which cranial nerve fibers are found at a point where you have put the arrow mark? Is it now number 3, 4, 6 or 7? And we need to know they are basically talking about facial colliculus in the lower pons, on the dorsal side, one rounder elevation at the floor of the fourth ventricle. So which nerve fibers produce the facial colliculus? Though it is understood the nucleus deep to facial colliculus belong to nerve number 6, the abducent nucleus. But abducent nucleus is not producing the facial colliculus. As the name is suggesting, it is produced by the fibers of facial nerve. Facial nerve nucleus is slightly more anterior and its fibers go posterior, loop around the abducent nucleus and exit out anteriorly at the pontomedullary junction. This is the pons region, this is the medulla, this is pontomedullary junction, this is the facial nerve coming out. And hence the answer should be choice number D, the facial nerve fibers. As the question was asking, which nerve fibers are found at the point of the arrow marked region, which is nothing but the facial colliculus, produced by the fibers of the facial nerve. Remember, the abducent nerve fibers, they'll be going anterior, also exiting at the pontomedullary junction. Superiorly is the pons, inferiorly is the medulla oblongata. The number 6, 7 both exit the brainstem at pontomedullary junction, but the answer should be choice number D. Let us take one transverse section at the level of lower pons to look at the facial colliculus and also talk about the floor of the fourth ventricle having a roof of the cerebellum, floor of the brainstem, mostly pons. The section would be something like this, a transverse section at the level of facial colliculus. This transverse section you can now discuss here as well. You see the abducent nucleus here at the floor of the fourth ventricle. On either side of the midline, we have taken this section at the caudal pons or lower pons. This is anterior, this is posterior. Posteriorly will have the cerebellum here as the roof of the fourth ventricle, and at the floor you have the lower pons more anteriorly. So this is the lower pons and this is the fourth ventricle filled with the CSF. In a transverse section, this is the region of the fourth ventricle. Then what about the fibers of the abducent nerve going anteriorly? You can show them here, the abducent nucleus, sending the fibers anteriorly as evident on both the sides. Then what about the fibers of the facial nerve? The facial nerve nucleus is more anterior, but the fibers are coming posterior, looping around the abducent nucleus, which you can show here. The facial nerve nucleus in the lower pons more anteriorly and sending the fibers posteriorly, which are looping around the abducent nucleus, but then they have to come anteriorly. And you can notice this is the facial nerve now coming anterior on this side as well as other side. The nucleus sending the fibers looping around the abducent nucleus and then coming anteriorly, the facial nerve fibers. In the process, this bend of the facial nerve, which is called internal genu of the facial nerve, looping around the abducent nucleus produce a rounded elevation. That rounded elevation is the facial colliculus the examiner was asking about. And this facial colliculus, where you had the arrow mark, is due to the fibers of facial nerve at the floor of the fourth ventricle. And then we can go back to our question, asking us which cranial nerve fibers are found at this point. The point is basically the facial colliculus, and the fibers are that of the facial nerve. Hence the answer to this particular question is choice number D here. Now, some of the students were telling that the arrow mark was actually here at the level of superior medullary velum. If it is at the level of superior medullary velum, then the nerve found here will be the trochlear nerve, cranial nerve number 4, which is coming from the midbrain region, the nucleus lying at the level of inferior colliculus. But most of the students told the arrow mark was at the level of lower pons. Hence, if that is the scenario, we should mark our answer as facial nerve fibers, choice number D. The present question is on the inferior thyroid artery and asking which all structure it is going to supply. The name is suggesting it obviously is going to supply the thyroid gland. Not only thyroid gland, it also supplies the parathyroid gland lying posterior to the thyroid gland. Plus we know that it is going to supply the inferior portion of the esophagus as it is passing through the neck region, moving towards the thorax region. Then if you read Gray's Anatomy, it is mentioned thymus is being supplied by inferior thyroid artery, sometime even the superior thyroid artery, though the major artery supplied to thymus is internal thoracic artery because thymus migrates from the neck region towards the anterior mediastinum, where you have internal thoracic artery giving the pericardiophrenic branches also to supply the thymus. But the point is, here all the four structures are being supplied by inferior thyroid artery, so our answer should be A, B, C, D, or choice number C should be our answer. Now, once you have found your answer, let us look at one diagram as well to mention some more details. So here basically we are looking from the front view, talking about the inferior thyroid artery, which is going to supply the thyroid gland, which is in the neck region, and also the parathyroid glands, which are lying posterior to the thyroid. But along with that, the inferior thyroid artery is also supplying the esophagus passing in the neck region towards the thorax region. This inferior thyroid artery is a branch of the first part of the subclavian artery being given by thyrocervical trunk. So, the first part of the subclavian artery is giving us the thyrocervical trunk, which itself is giving the inferior thyroid artery. And this inferior thyroid artery, as shown on the other side as well, is going to supply the thyroid gland and the parathyroid gland. But then be careful, it'll keep giving several branches like tracheal branches to supply trachea, laryngeal branches to supply the larynx, esophageal branches to supply esophagus, and thymic branches to supply the thymus as well. Developmentally, the thymus will be migrating from the neck region to the superior mediastinum to the anterior mediastinum, and that is the final location of the thymus. Near to that comes the internal thoracic artery, which is also coming from the first part of the subclavian artery on either side. So internal thoracic artery will be supplying the thymus gland majorly, and also by giving the pericardiophrenic arteries, which continues supplying the thymus gland. Thymus gland is being supplied by the inferior thyroid artery also. And remember, thymus, the venous drainage is in the similar fashion towards internal thoracic vein, pericardiophrenic veins, and towards inferior thyroid veins as well. So you have to understand, whenever a question comes, we obviously have to find out the answer, but then we have to work upon the topic in detail. We should talk about thymus not only in terms of the arterial supply, but also the venous drainage. Just keep moving around the topic, increasing your circle of activity, but you should also know your limits. Obviously, we cannot start doing PhD on thymus gland if a question has come. So where are the limits? It is the previous year questions we keep practicing. Those decide the boundary lines. As we read the details given by the examiner, mentioning the patient met with an accident, there is some fracture at the skull base at the level of temporo-occipital region, and then presenting with difficulty in speech post-trauma. If you say difficulty in speech, it could be involving the muscle of larynx, something wrong with the vagus nerve. Why I say so specifically? Because in the temporo-occipital region, if there's a fractured skull base, there you have jugular foramen. And in the jugular foramen, you have the number 9, 10, 11. So maybe it is a problem with the number 9, 10, 11, the features of Wernicke syndrome or the jugular foramen syndrome. Then further, when we are doing the investigation, which structure should you be examining so as to confirm your diagnosis? And then they have put some marking. A, B, C, D. It is the sagittal section of the head and neck region. Marker A is actually at the roof of the nasal cavity, the olfactory region. Cranial number 1, they might be talking about, or they have put a marking. B on the soft palate, the uvula, which might be tested for lesions of the number 9 or 10. Marker C is on the tongue, which is basically the hypoglossal nerve, cranial number 12, or they are putting the marker D on the larynx. Obviously, it is about the vagus nerve, mostly. So, what should be our answer? A, B, C, D. Since we are thinking in terms of the Wernicke syndrome, The nerve involved are the number 9, 10, and 11. Passing the jugular foramen, so the structure which we'll be examining at the very outset will be the soft palate, the uvula. Look at the central alignment of the uvula. Whichever side we have the one-net syndrome, the uvula will be deviated to the normal side. You are checking for the 10th nerve, especially when you ask the patient to say, let me show you the diagram. Or you could check for the 9th nerve as well. The gag reflex, touch the posterior pharynx wall, and there will be a reflex spasm of the muscles. Let us look at the details. But then the answer should be something related with the uvula. Choice number B should be our answer. And we have a lot of details to talk about. Let me take you to the skull base and the temporo-occipital region. That is where we have got the jugular foramen. This is looking from the superior view. We have removed the skull cap, the brain, so that we are looking at the floor of the cranial fossa or the base of the skull. And at the base of the skull, we want to look at the green bone, the occipital bone, the violet bone, the temporal bone. Between the two, we have got a fracture, temporo-occipital region. Most probably, it was involvement of the jugular foramen here. So, what are the contents of the jugular foramen? Number 9 to 11, and the dural venous sinus draining into the internal jugular vein. If internal jugular vein is involved or the draining venous sinus is involved, there will be raised intracranial tension, papilledema, all that, which will be evident. But this is not a question going in those lines. It is something about the sensory motor problems might be arising due to involvement of number 9, 10, 11 passing the jugular foramen, the one-net syndrome. So how do you test the number 9 or number 10 or 11? Here we are looking from the front view and we have asked the patient to open his mouth, and what you are doing is stimulating the posterior pharyngeal wall, or maybe you are stimulating the region which has sensory supply by 9th nerve, the tonsillar region, the soft palate, posterior 1/3 of tongue or posterior pharynx wall. So when it comes to this oropharyngeal isthmus or posterior pharynx wall, you're testing the 9th nerve, the gag reflex. As you touch this region, and if the 9th nerve is working properly, there'll be a sudden spasm of the muscles of palate, pharynx and larynx, because 9th nerve is taking the information towards the nucleus tractus solitarius in the gag reflex, and nucleus tractus solitarius, which is a sensory nucleus, will be activating the motor nucleus, the nucleus ambiguus, and the nucleus ambiguus, which is having the nucleus of number 9, 10, 11, will be activating the muscles of palate, pharynx and larynx. As they undergo contraction, there will be a sudden swallowing movement. So that is about the 9th nerve as well as the 10th nerve. Sensory component 9th nerve, motor component 10th nerve, with minor contribution from 9th. But be careful. If you want to check the 9th nerve, you do the gag reflex. More specifically, if you want to check the 10th nerve, what is the first thing you do? Just ask the patient to open the mouth and say, When the patient say, there'll be 10th nerve working upon the soft palate muscles, which will be undergoing contraction. Say, for example, the patient has one-head syndrome of left side, 10th nerve is involved. So left-sided palatal muscles will be flaccid. They'll not undergo contraction. Whereas the normal side, right side, muscles will be undergoing in contracture. In that process, the uvula, which is a midline structure, will be pulled towards the normal side. As you see here, this is a case of uvula being pulled towards the right side. Let me zoom this region a little bit. The uvula is not in the midline. It is a case of left-sided vagus nerve being compromised. So if the left vagus is not working, the left-sided palatal muscles will not contract. The palate will not be elevated. In fact, it will be sagging down. Whereas on the normal side, that is the right side, the palatal muscles are contracting properly. They will be elevated. In that process of one side sagging down, the other side moving upward, the uvula is pulled towards the normal side. One-head syndrome on the left side. And this becomes more prominent when the patient says, and this is a specific test which you can do for vagus nerve. And of course, for vagus nerve, you can do laryngoscopy, unilateral paralysis of the larynx muscles, the vocal cord position can be noted. What about the 11th nerve? If 11th nerve is compromised, there will be drooping of shoulder because trapezius is compromised and the neck cannot turn properly to the contralateral side. Sternocleidomastoid and trapezius, both supplied by 11th nerve, if compromised, it will become evident just by looking at the patient or asking him to shrug the shoulder or turn the neck to the opposite side. One-Net syndrome on the left side involving 11th nerve you can make out very quickly. Now let us go back to our question. As is evident, the fracture at the temporooccipital region, Jugular Foramen syndrome, the number 9, 10, 11 involved, with the patient having problem with speaking. Our focus goes on to nerve number 10. And how do you check 10th nerve? By asking the patient to say ah or the midline position of uvula, choice number B. Hence the answer should be choice number B. We are actually talking about One-Net syndrome here. This diagram shows the superior view of the C1 vertebra, the atlas vertebra, and the question is being asked upon the third part of the vertebral artery. We understand vertebral artery has 4 parts, and when it comes to the third part of vertebral artery, most of the books, including Gray's Anatomy and BD Charasya, they'll be showing it running on the superior aspect of the atlas vertebra. Let me mark the course. This is the anterior arch of the atlas vertebra. This is the posterior arch, and on the posterior arch, we find the vertebral artery making a groove. So this is the location where you will find the vertebral artery. Choice number D should be our answer. Now, when you mention the answer is choice number D, fine, but then what about the choice number C, which is foramen transversarium? As I mentioned, in BD Charasya and Gray's Anatomy, choice number C, foramen transversarium, will have the second part of vertebral artery becoming the third part of vertebral artery. That means in the foramen transversarium, it is the transition zone. You can mention this also as your answer. Means choice number D is obviously your answer, which if not given, you may take your answer as choice number C as well. Since choice number C has the second part of vertebral artery converting itself into third part of vertebral artery. Let me give you some more details. But then what is this choice number A and B? Choice number A is the anterior arch of the atlas vertebra, the C1 vertebra, cervical one, and choice number B is the vertebral canal through which the spinal cord will be passing. It will be giving a C1 spinal nerve also, which is lying here on the posterior arch of the atlas vertebra along with the third part of vertebral artery. Let us look at some more details about the vertebral artery. As we understand, vertebral artery is a branch from the first part of the subclavian artery, and the vertebral artery itself will be having 4 parts. The first part of vertebral artery reaches till the foramen transversarium of C6 vertebra as shown here, and after that, as it enters the foramen transversarium of the C6 vertebra, it continues as the second part of the vertebral artery, reaching till the foramen transversarium of the C2 vertebra. So this is the second part of the vertebral artery. Then after passing the foramen transversarium of C2 vertebra, it changes into third part of vertebral artery. Now this third part of vertebral artery, there is difference of opinion between various authors. There are few authors which will say the third part of vertebral artery will have 2 segments, one vertical segment and one horizontal segment. The vertical segment of the third part of vertebral artery starts from the foramen transversarium of C2 vertebra, the axis vertebra, and reaches the foramen transversarium of C1 vertebra, the atlas vertebra. So from the foramen transversarium of C2 to C1, that is the vertical part of the third part of vertebral artery, and then there is a horizontal segment. The horizontal segment lies in the suboccipital triangle and is considered coming out of the foramen transversarium, lying over the posterior arch of the atlas vertebra on its superior aspect until it pierces the atlanto-occipital membrane and the dura mater arachnoid mater to enter subarachnoid space, because once it enters the subarachnoid space, you will start calling it as fourth part of vertebral artery. So fourth part of vertebral artery is actually in the subarachnoid space. Now, coming back to third part, I have mentioned there are two segments, the vertical segment and the horizontal segment. The horizontal segment of third part of vertebral artery is shown here. Coming out from the foramen transversarium of the C1 vertebra, atlas vertebra, running on the posterior arch and then puncturing the atlanto-occipital membrane on the posterior aspect and puncturing the dura mater as well as the arachnoid mater to enter the subarachnoid space. But once it is in the subarachnoid space, it is the fourth part. Before that, it is the third part. This is the horizontal segment of the third part of vertebral artery. And this is what is mentioned in Gray's Anatomy and BD Chorussia. They do not mention about the vertical segment, which very few authors do. So, then what is this part as per Gray's Anatomy or BD Chorussia, lying between the foramen transversarium of C to C1? They consider it as second part only. So, where is the third part then? It is lying on the posterior arch of the atlas vertebra. That is why I mention, if you talk about the third part of vertebral artery, the best answer will be posterior arch of atlas vertebra here. But if that option is not available, you can take your second answer as even the foramen transversarium, because obviously it is the junction of second and third part of vertebral artery. So our question will have double answer, but preferably we should choose our answer as superior aspect of the posterior vertebral arch. Let us go back to the question again. And obviously, if you are talking about third part of vertebral artery, the best answer will be superior aspect of the posterior arch of the atlas vertebra, marker D. If marker D is not given, you may take your answer as marker C as well, because that is the point where second part of vertebral artery is changing into third part of vertebral artery. As we understand, this is the posterior thoracic wall. We can see the vertebral arch here and cut section of the ribs on the right side as well as left side. The marker is on a vein which is running towards the right side of the midline and is none other than the azygous vein. Now, if that is the azygous vein, they are asking us about its embryological origin, and it will be the veins which are draining the thoracic wall. So, which veins drain the thoracic wall? The azygous venous system. What about their embryological origin? Embryologically, they are derived from supracardinal veins. So, where is the answer? It is choice number B here, but then we need more details. Why we have taken our answer as supracardinal vein? And what else it will be contributing towards? What about this subcardinal, common cardinal, or sacrocardinal veins? Let us look at them in some more details. We actually have several names for the cardinal veins, which are the embryonic veins, and then we want to know what are their adult derivatives. And in the beginning, embryologically, we'll find we have got anterior posterior cardinal vein. They join to form the common cardinal vein. Along with that, we also have the subcardinal and supracardinal vein. The anterior cardinal vein contributes towards the superior vena cava, whereas posterior cardinal or supra-subcardinal contribute towards the inferior vena cava. Inferior vena cava as such will have several portions and being contributed by posterior, subcardinal, supracardinal. Let us first put them as they are in the embryonic stage. So we have got anterior cardinal veins on right side and left side, and then we have got posterior cardinal veins as well. The posterior cardinal veins are draining the lower body, whereas anterior cardinal veins are draining the upper body. Together they join to form common cardinal vein, which will be on the right side as well as left side, and then these common cardinal veins, which have formed by the joining of anterior posterior cardinal vein, drain into the heart in the most simplistic fashion. Now, obviously, the anterior cardinal veins, since they are in the head neck region, upper limb region, they'll be contributing towards the internal jugular vein and superior vena cava as seen here. So, anterior cardinal vein contribute to superior vena cava and internal jugular vein, basically draining the head neck region or the upper body. Anterior cardinal veins are for draining the upper body. What about the posterior cardinal vein? Posterior cardinal vein will be gradually disappearing and their place will be taken by some other cardinal veins. But then posterior cardinal vein will have some contribution to the inferior vena cava and and part of the common iliac veins. In fact, common iliac veins join to form inferior vena cava. So the beginning of inferior vena cava come from posterior cardinal vein, which we can show here in the diagram now. So as we talk about common iliac veins in the pelvis region contributing to inferior vena cava, which is in the abdomen region, you can show them here. Common iliac veins join and then they form the inferior vena cava. And this initial part of inferior vena cava is definitely contributed by the posterior cardinal vein. Some books will mention it as sacrocardinal vein. So you can mention here sacrocardinal vein as well. So this posterior cardinal vein or sacrocardinal vein will form the initial portion of the inferior vena cava and also contributing to the common iliac veins. What about the next portion of the inferior vena cava? The next portion of inferior vena cava we will definitely talk about, keeping it as a query here. But then if it comes to the renal portion of inferior vena cava, the renal veins draining the kidneys, that area is contributed by the subcardinal veins. So here you can see the subcardinal veins contribute to the renal portion of inferior vena cava, also the renal veins as such. The gonadal veins are also coming from here, which drain into the renal vein, which will drain into the inferior vena cava, related with the kidneys. So renal segment of inferior vena cava, the renal veins, gonadal veins, they are all coming from subcardinal vein embryologically. But then what about this portion which you have put a query here? That is where you will see the contribution, which is infrarenal parts of the inferior vena cava. The inferior vena cava, which is below the kidneys, that portion is coming from supracardinal vein. And this supracardinal vein not only form the infrarenal portion of inferior vena cava, it is also draining the thoracic region by intercostal vein and azygous venous system. If you remember, I have mentioned azygous veins are basically developing from supracardinal veins, and supracardinal vein also contribute to infrarenal segment of inferior vena cava. So you can understand it is not so simple. The development of inferior vena cava need more details. But our job here is not to discuss those details because it is a long topic. We are just having a brief overview and can be well understood by looking at another diagram. So it will be a repeat information, but we have seen that the anterior cardinal veins are for the upper body contributing to superior vena cava, internal jugular vein, which can be seen here in the diagram as well. This is the anterior cardinal vein of the right side, and the same can be shown on the left side. And they'll be contributing to the internal jugular vein, maybe on the right side or left side. So, not only the internal jugular veins will develop from the anterior cardinal veins, they will also contribute to superior vena cava, as is seen here. Superior vena cava, draining the upper body into the heart. Then what about the posterior cardinal veins? When we are talking about the posterior cardinal veins, they contribute to initial part of inferior vena cava and the common iliac veins. We have mentioned that earlier, and let us show that here as well. The posterior cardinal veins, which are shown here, are regressing. Most of them will regress and will be replaced by another system of the cardinal veins, but they do leave behind the common iliac veins in the pelvic region and beginning portion of inferior vena cava. Then, if you remember, I have mentioned some books calling it as the sacrocardinal segment of the inferior vena cava. You call it as posterior cardinal or sacrocardinal. It is the beginning of inferior vena cava by the joining of common iliac vein. So initial portion of inferior vena cava has been contributed. What about the next portion of inferior vena cava? That is where we had put one query. And if you remember, this infrarenal segment of inferior vena cava would have come from the supracardinal veins. The supracardinal veins not only contribute to infrarenal segment of inferior vena cava, they also drain the thoracic region and contributing to azygous venous system. So maybe it is hemiazygous vein or azygous vein. They are being contributed by the supracardinal veins. You see here, these are the supracardinal veins. They are supposed to be draining the thorax region, and not only they drain the thorax region, they have contributed to a part of inferior vena cava, which is infrarenal segment of inferior vena cava. Look at the table again. As you notice, supracarnal veins contribute to infrarenal portion of inferior vena cava and drain the thoracic region by intercostal veins and azygous veins. Now, the vein which is left to discuss is subcardinal vein. Subcardinal is the vein which will contribute to renal segment of IVC, renal vein, gonadal veins, and which you can show now. The subcardinal veins contributing to renal veins and renal segment of inferior vena cava. Better seen here, the renal veins, the gonadal veins, and the renal segment of inferior vena cava. That is all coming from subcardinal vein. Now, obviously, it is a detailed description and we are not supposed to discuss it here that way. Our job was which veins drain the thoracic region, that is the azygous venous system, and where is the embryological origin of azygous venous system? The supracardinal vein. Supracardinal vein also contribute to one portion of inferior vena cava. Which portion? That is the infrarenal segment of inferior vena cava. Anyhow, let us go back to the question. What it was asking? It was asking what is the embryological origin of the marked vein. The marked vein is draining the thorax. It is azygous venous system. Azygous venous system is contributed by the supracardinal vein. Of course, the answer is choice number B. Can you tell me which parts of inferior vena cava is contributed by the supracardinal vein? It is that part of inferior vena cava which is below the kidney. And what is the initial part of inferior vena cava contributed by? That is posterior cardinal vein. Some books calling it as sacrocardinal vein. So, this sacrocardinal vein contributes to the initial portion of inferior vena cava. What about this subcardinal vein? The subcardinal vein contribute to gonadal vein, renal vein, and renal segment of inferior vena cava. As you can draw it yourself, this is common iliac vein draining into inferior vena cava. But embryologically, the common iliac vein and initial part of inferior vena cava will come from which embryological origin? It is the posterior cardinal vein, also called sacrocardinal vein. And what about this portion of inferior vena cava? That is from the supracardinal vein. And what about the renal segment? If you are talking about the renal segment of inferior vena cava, that is from the subcardinal vein. So inferior vena cava has got contribution from posterior or sacrocardinal vein in the beginning. After that, it is the supracardinal vein which also form the azygous venous system in the thorax. And after that, it is a subcardinal vein which contribute not only to renal IVC but also renal vein and gonadal veins. Too much of details? I have only one advice. Keep practicing previous year questions and keep your answer as choice number B here. We got a patient who was mentioned to have a fall from height and was put into some cast. After removal of the cast, we see the patient is unable to walk properly, could not lift the leg, was dragging his foot on the ground while walking. So which of the following marked structure has been compromised? And what we find is the muscles in the gluteal region. This is the thickest nerve of our body. Marker D is the sciatic nerve here. Along with the sciatic nerve, we have got some other nerves. This one going upward and supplying a very large muscle here, the gluteus maximus is the inferior gluteal nerve. Both of them come below a muscle marked here. The marker C is a muscle which is piriformis muscle. This piriformis muscle is attaching to the tip of the greater trochanter on the bone femur. So, what are the structures which are passing below piriformis? They are sciatic nerve and inferior gluteal nerve. The inferior gluteal nerve which is supposed to supply gluteus maximus. But none of that is of any concern to us. Actually, this kind of a history is suggestive of patient having Tunnelane test positive, dragging the foot, and will subsequently start walking with the lurching gait. The hip abductor mechanism has been compromised. So our answer cannot be choice number D because sciatic nerve has nothing to do with that, and cannot be choice number C because even piriformis has nothing to do with that. So then what is the answer? Choice number B or A? Choice number A is the largest muscle in the gluteal region, the gluteus maximus. that was being supplied by this inferior gluteal nerve. Let me just demarcate the gluteus maximus here. So this is the gluteus maximus muscle. And in fact, we have cut a window in the gluteus maximus muscle, as you can see here, so as to see the structures under cover of gluteus maximus. So this marker A is the gluteus maximus. And again, it has nothing to do with the description we have got. That means the answer is choice number B. Yes, the answer is choice number B. But who exactly is choice number B? It is a muscle. Which muscle it is? The muscle which you can see only once you have cut the gluteus maximus. It is under cover of that. It is called gluteus medius muscle, and it is the gluteus medius muscle which is important for the hip abductor mechanism, and if that mechanism is compromised, we will have the Trendelenburg test positive. Now let us look at some more details here. Let us look at the gluteal region in another diagram. It is the same diagram with the schematic diagram, and we are looking from the posterior view. This is the gluteal region on the right side, and the largest muscle has been cut here to see the structures under cover of that. This is the gluteus maximus muscle, which we can mark here, is being supplied by the inferior gluteal nerve, which passes inferior to the piriformis muscle. So gluteus maximus being supplied by the inferior gluteal nerve, which is passing inferior to the piriformis muscle. The same you can mention here as well. This is the gluteus maximus muscle, and which has been cut so as to see the structures deeper to it. Then what do you see deep to it? We find after cutting the gluteus maximus, we can visualize the gluteus medius, which lies deeper and slightly anterior to the gluteus maximus. Now, if that is the gluteus medius, you can show the same in the diagram again here. This is the gluteus medius, which cannot be seen until we cut the gluteus maximus. And once we cut the gluteus medius, deep to that is gluteus minimus, which lies yet more deeper and anterior comparatively. So this is gluteus minimus. And the most anterior muscle is tensor fascia lata. These three muscles are called as the trio muscle, and they have a nerve supply superior gluteal nerve. Superior gluteal nerve passes superior to piriformis muscle, supplying the three muscles which work for abductor mechanism at the hip joint. So here is the superior gluteal nerve supplying the three muscles and helping us for abductor mechanism at the hip joint. It passes superior to piriformis, hence the name superior gluteal nerve. Inferior gluteal nerve passes inferior to piriformis. It was supplying gluteus maximus there. So can you show superior gluteal nerve in this diagram? Yes, it is passing superior to piriformis. Here is the superior gluteal nerve supplying gluteus medius. And not only it will supply gluteus medius, it will supply the trio muscle, the gluteus medius, gluteus minimus, and tensor fascia lata for abductor mechanism. Now, the patient who had a fall from a height might have got compromised abductor mechanism involving this muscle, gluteus medius, or the nerve, superior gluteal nerve, or there are chances that there was some bony injury. The head of the femur or neck of the femur might have been compromised because they also work for abductor mechanism. Let us look at some more details now. So what exactly is this abductor mechanism at the hip joint? See, normally when we raise 1 foot off the ground, say for example for walking purpose, as the foot goes off the ground, it is called swing phase of walking cycle. At that moment, the other foot must be on the ground, and the one which is on the ground is stance phase. Now obviously when one of the foot goes into air, say for example, since you are looking from posterior view, this is the left leg. The left leg is going into the air. The gravity will pull the left pelvis down, but it doesn't fall down. And why? Because that gravity is being counteracted by the trio muscles from the opposite side. And who is this trio muscles? The trio muscles are gluteus medius, minimus, and tensor fascia lata, supplied by superior gluteal nerve. So what do they do? Normally, their function is pull the femur away from the midline. That means they cause abduction at the hip joint. But since the foot is fixed to the ground, now the femur cannot be pulled and their origin insertion will interchange. Their movement will change. Since these trio muscles cannot move the femur attachment is no more the insertion. It becomes origin. Then where is the insertion? It is on the hip bone. That means they'll be now moving the hip bone. Yes. How? See, insertion always goes close towards the origin. What does that mean? That means they'll be pulling this pelvis down. And what is the purpose of pulling this pelvis down? To counteract the gravity on the other side, which was pulling the left pelvis down. So basically, the gravity is being counteracted by the contralateral trio muscles or superior gluteal nerve, and the pelvis remains in a balanced state. There is no excessive pelvic tilt. You'll understand this better when I mention the patient who had a fall from height, had a fracture neck of femur or head of femur, or maybe superior gluteal nerve was involved. The trio muscles were not working. Compromised abductor mechanism. Now let us see what will happen. In that scenario, the pelvis cannot be pulled down on this side and obviously leading to excessive pelvic tilt on the side where the foot goes into air. So wherever you have the swing phase, the pelvis will drop down. Limb length will become more. The foot will be dragging on the ground. That was the problem of the patient. This patient was dragging his foot on the ground, could not lift it because there was a problem with the abductor mechanism on the other side. And these patients will have Trendelenburg test positive. As you ask the patient to stand on one leg, the side which is having a pathology, the normal sided pelvis drops down. That is Trendelenburg test positive. And gradually, they will learn to contract that by developing a lurching gait. Let me show that in the next diagram now. So this is the normal scenario we were talking about. When one foot is in the air, gravity pulls the pelvis down, which is being counteracted by abductor mechanism on the other side, pulling the pelvis down, and the pelvis remains at a particular horizontal level. But if something goes wrong on this side, there'll be excessive pelvic tilt because gravity is not being counteracted. See here. In this patient, there's a problem on the right-sided abductor mechanism, which could be either the glutei muscles are not working, the medius and minimus, or could be superior gluteal nerve injury, could be a fracture, neck femur, head femur. And what is not happening? As the patient takes the foot off the ground, swing phase, the pelvis being pulled by gravity and excessive pelvic tilt. The limb length is more, dragging of the foot. During the course of disease, patient learns to counteract that. This Trendelenburg test has become positive and the patient will now develop lurching gait. What is lurching gait then? Actually, to take this foot off the ground, the patient learns to bend his spine towards the same side of the lesion. If there was insufficiency on the right-sided pelvic region, the spine will tilt to the right side so that the patient is able to raise the dragging foot on the ground above and walk properly. So he will lurch. Patient will lurch to the same side of the lesion to clear the foot off the ground, that foot which was actually on the normal side. So this is called as lurching gait. Patient lurches towards the same side of the lesion, wherever the abductor mechanism was compromised. Now we go back to our question. So let us read the question again. It is a patient who had a fall from height, maybe some fracture, neck femur, head femur, and for that purpose there was a cast. After removal of the cast, we find patient unable to walk properly, unable to lift the leg properly, there was a dragging of foot. So which structure is compromised? Abductor mechanism. And which muscles are for abduction? The gluteus medius, gluteus minimus, tensor fascia lata. So marker B is the gluteus medius supplied by this nerve passing above the piriformis, superior gluteal nerve. Choice B should be our answer. What is this marker marker A. Marker A is the large muscle in which we have put a window. It is gluteus maximus. And what about this red muscle here attaching to the tip of the gator trochanter? Marker C, that is piriformis muscle. And what about this largest nerve of our body passing below the piriformis? Marker D, that is sciatic nerve. Nothing to do with that here. So we'll keep our answer as choice number B, or gluteus medius muscle, which can be seen only once you have cut a window in gluteus maximus.